Welcome to the Conquering Your Fibromyalgia podcast. I'm your host, Dr. Michael Lenz. I am a pediatrician, an internal medicine physician, lifestyle medicine certified, as well as clinical lipidology, and author of the book Conquering Your Fibromyalgia, Real Answers and Real Solutions for Real Pain. And today we're going to talk about a topic that has gotten a lot of discussion over the last several years and often is very confusing, yet there are some things that are straightforward. I have a special guest. His name is Dr. Zach Telfer. He's a PGY4, which means he's in his fourth year of a 4-year residency in combined internal medicine and pediatrics, and he is planning on starting a infectious disease fellowship next summer. So, and Jack is, I know him for now over 3 years because he's gone to my clinic about once a week, getting a chance to learn outpatient pediatrics and internal medicine. And he's been exposed to fibromyalgia and related problems as far as seeing patients in the clinic. So welcome to the podcast, Zach.
Well, thank you so much for having me. I'm happy to be here. I've heard all about it in clinic.
All right. Well, glad I know you've listened to a few episodes. Being a medical resident is very busy. Getting into medical school, can you tell us about your story about getting into med school, what you did before? I think it's a little interesting path into medical school. And
Yeah. So I started off in just rural Wisconsin, growing up with parents from dairy farms, so very standard Wisconsin family. And I decided in high school that I wanted to pursue college. I didn't quite know what I wanted to do, but I went to undergraduate training in Oshkosh, Wisconsin, and I fell in love with parasites, oddly enough. I had found a podcast, actually. I probably don't need to plug it here, but it was a parasite podcast that's fairly popular. And I ended up buying a textbook online just for fun. And I would read about parasites, and I decided, oh, I really like microbiology. I like biology. So I started learning about medicine and what it took to go into medicine. And I decided to become pre-med, which is not necessarily a major, but it's a distinction where we decide, oh, I'm going to go to med school, so I probably should take the classes that will get me there. And so I had a major in biology and microbiology. So I had 2 degrees, and the microbiology was mostly because I love parasites and microorganisms early on. And I decided to pursue medical training, and I decided to stay in Milwaukee. I moved to Milwaukee for medical school. I did 4 years here, and I decided to continue my parasite work. And I worked with schistosomiasis, which is a parasitic disease that happens in Africa. And it's a human disease, but there's actually oh man, that's a mouthful. Schistosomiasis in Wisconsin, and we call that swimmer's itch. And so it's a bird disease, but we get it in the skin and causes itchiness. And so it's kind of interesting. It's a little nerdy, but then decided to stay in Milwaukee for my residency training. So after 4 years of medical school, I decided to go on to my med peds training, and now I'm in my 4th year, like you said.
so why did you decide to become a med peds resident, go into that field? What drew you to that?
Yeah, I think the time that I spent in medical school, I spent a lot of time studying global health, and I was studying parasitic diseases and neglected tropical diseases. And I spent time in Africa. I saw a lot of nonprofit organizations that were providing medical care to the village that I was staying in. And I started to see that there were people that would come to Africa or go to these places in the world that are developing, and they would practice outside their scope of medicine that they would normally practice in at home. So maybe for example, there's an Australian adult anesthesiologist coming to Africa and providing pediatric care. That's not their scope of practice. They're not board certified in it. And it made me feel uncomfortable that in the future, if I wanted to pursue global health, that I wouldn't have training in either pediatrics or medicine. So I felt that if I wanted to better treat and educate people on diseases, especially infectious disease ones, I would want to be board certified in both kids and adults.
Yeah, sounds great. That's a lot of people pick both. You get a chance to be an expert in pediatrics and internal medicine, and infectious disease is really great because so many of the disease pathogens overlap, and your understanding, it helps you, I think, in training. When you're a pediatrician, it helps you become a better internist, and when you're an internist, it makes you a better pediatrician. And I find that probably, as you know, with a lot of your peers, tend to be pretty driven people wanting to take on 2 board certifications instead of just settling for one.
Yeah. Well, I'm sure people ask you all the time, but why didn't you just choose family medicine, if you wanted to treat the spectrum? And I don't know if you have an answer that you've talked about on the podcast before, but
I never really brought that up. But the reason I had, and one is I thought that's what I would be. I never even heard of what internal medicine or pediatrics was. I remember working out at Wisconsin Lutheran College across the street from the medical college, and there was somebody probably 2 years older than me who had just matched in this thing called Med Peds, internal medicine Peds, and I'm like, well, what's that? And I started hearing about it. And I'm like, oh, well, that sounds cool. And I'm a guy, and I don't think that doing obstetrics is going to be a big draw. It wasn't a huge interest, nothing against that, but I knew that I probably wouldn't be practicing that anyway. So why not get an extra year of training plus minus the 6 months of doing obstetrics and become interested in learning so much more in depth? I think there's a different mentality. I think part of the internal medicine mindset, especially, is being that detective and trying to problem solve and figure things out in a non-operative fashion. But it did leave the door open for some who go on and become infectious disease, some become cardiology trained, some do GI. So there's still that potential to do both. It can be frustrating for so many patients who are struggling with fibromyalgia and related problems, and we'll be talking about chronic Lyme and post-Lyme treatment disease and different names we can call that later in this discussion. But talk about how much you have to learn just in medical school, let alone residency, to get a sense, because it sometimes can feel, when you have the fibromyalgia related issues, that your doctor just didn't learn anything. How much did you learn in medical school, just overall? What was it like going through medical school and trying to learn in 4 years?
Yeah, well, I won't pretend that I'm unique, but I do think I'm a bit of a glutton for punishment. I think I talked about my undergrad training where I did both biology and microbiology. Then I decided to do medicine and pediatrics. And in the future, I hope that I can do both infectious disease for adults and pediatrics. But every time that I start in a new school and a new training program, there's thousands or millions of things that we end up learning at each stage. And, we're tested on it and we have to put it into practice. And if you've ever tried to remember all of that information or even remember names and birth dates, that it's difficult. So, all the things that we learn, we learn over and over again, and we practice by repetition. And there are some things that come up more often and they're easier to remember. And there's things that come up less often and it's not as easy to remember. Or there's some things that people feel uncomfortable about and don't ever talk about. So, I would say that this podcast caters to the things that we are uncomfortable talking about in medicine, and potentially that's why in medical training we don't see it as often and we don't talk about it as often, and people are then uncomfortable with this topic and then don't teach about it, and then the cycle continues. But for the most part, we're learning about thousands of disease processes and their treatments, and then what makes them different, what makes them similar, and we're coming up different tests that we have to use to come up with an answer. So we're learning a lot of things, and so it's hard to keep that all in our head all at once. And so it's really about repetition and how common you see things.
I think having a son just starting medical school, I think that the analogy sometimes can be like trying to take a drink from a fire hose or a waterfall. There's so much, and part of that is having some context and understanding to how common something is and how to look at it clinically and with real people who are struggling with a health problem, no matter what it is. And so you learn that huge volume, you get a little taste of it with clinical rotations, and then you get into your medical residency. And during medical residency, you get to now get more exposure to medical problems to help get expertise in training in both inpatient and pediatrics and internal medicine for med peds, and in an outpatient rotation. Part of why I enjoy having residents is I want to make sure you have a good experience, a good exposure, a good taste. I know that going into this, I've had at least one parasite infection for one of my patients. I know that has happened once with pig worms, at least once, but not. But you already had an idea to be going in infectious disease, and hopefully learning about fibromyalgia. I think you made a comment once that when you were first few months, even year of working with me and taking care of people who have fibromyalgia and related problems, I think this was a new thing, new exposure that you had not seen a lot. But I know you made comments in the last year that now you're like, okay, this is starting to kick in. And now when you apply that to other services you're on, whether it's pediatric gastroenterology and you're looking at cyclical vomiting syndrome,
Yeah.
and really seeing that, I think you've said that you're probably know more than most of the attendings on a lot of these diseases, and bringing up some of these comorbidities and asking questions to help.
Yeah, no, I think being part of your clinic has made me see that every specialty has their silo. Their, a farm reference, but they have their silo of information. And so each silo has this thing that sounds like fibromyalgia, it acts like fibromyalgia, or something on the spectrum, and no one is communicating across the different specialties. And so I'm starting to see it more. My eyes have been opened a little bit because, now today we're talking about, now we're in the infectious disease silo, and we have this post Lyme syndrome or chronic Lyme that, it seems to be a mystery to the ID doctors, and but we also have, like you said, cyclic vomiting in the GI world, and we have certain rheumatic diseases, even fibromyalgia, that sometimes are seen by rheumatologists. And then so I think it's really been eye-opening to work with you and to see the overlap in a lot of these syndromes.
And just being aware, at
Yeah.
least 10 million people in the United States have fibromyalgia and related problems. And when you start asking the right questions and start knowing what to look for, it's often more present than we often believe. As you're studying for your internal medicine boards, my last board exam had one question on the recertification about fibromyalgia. There were none, I believe, on the pediatric boards. So when you're in medical school, I'm sure you probably didn't even have any questions on any of your step 1 or step 2 boards on fibromyalgia. Did you even recall any off the top of your head?
Yeah, off the top of my head, I don't remember them, but in hindsight, I may have thought they had arthritis or something and got the
Got
question
the
wrong
question wrong.
because I wasn't actually reading the stem correctly. I wasn't picking up on the cues.
Yeah. And what medical schools are really trying to train or teach their students for the test to make sure they know, and the medical tests are set up so that these are what are thought to be the most important key topics to try to condense down that every medical student should basically know. So if you're on OB and there's somebody having a heart attack or a blood clot, no matter what rotation, everybody should recognize a heart attack or a blood clot. Everybody should probably recognize endocarditis, for example, and the other struggles and other medical problems along with that. So, talking about today, we have some things that are really straightforward or pretty straightforward when it comes to Lyme disease. And
Yeah.
then there are things that seem less straightforward. And then there's a lot of confusion. On one of the Facebook groups I'm on, there was a question like, well, why do we have to label things or get all fixated on diagnosis and everything? And I'm like, well, we need to, because that helps grow in our understanding. We have to classify things so that we can do studies and group patients, and we can grow in our understanding. Fibromyalgia is a syndrome of symptoms, and we try to grow in our understanding over time. So we are going to try to do our best to unpack and deconstruct this whole Lyme area. And there's a lot of confusion, I think, out there and misunderstanding. And I don't think traditional medicine spends enough time talking about, especially the chronic Lyme or post-Lyme syndrome type symptoms. And so talk about, I
Yeah.
know I've asked you to put some of your interest in infectious disease to do some spend time to talk about just what first is the history of Lyme. What is Lyme disease?
Yeah, I think there has always been a lot of mystery shrouded around Lyme disease, and it's a relatively recent discovery. Lyme has been around for thousands of years, millennia. We found it in mummified remains of cave people that have been frozen. So we know that Lyme has been around forever, but the actual disease of Lyme wasn't really even discovered until the 80s, like 1980s. It was actually because out in Lyme, Connecticut, where Lyme, where the disease gets its name, they were having this group of patients that were complaining of various symptoms. They were all suffering from different swollen knees, paralysis, rashes, headaches, and they were having chronic fatigue. And there was a lot of people that were communicating, and this is back before we had social media. There was a lot of these patients. Well, doctors were puzzled because we didn't have an exact diagnosis. They didn't know what was going on, and they started having certain groups that were getting together about these patients. So certain family members, it was happening in kids and adults, and there was actually a couple moms of some of the children with this disease that kind of advocated for more research to be done. They knew that there was something going on, something that was going on. So they had pushed for more research, and they actually did a really wonderful job pushing for it, because there was a researcher that was already researching different diseases that are transmitted by ticks. Someone that was studying Rocky Mountain spotted fever, also uh, caused by a tick bite, or not caused by a tick bite, but transmitted through a tick bite. And that was Willy Bergdorfer. And so ultimately in the 80s, he found out that a lot of these patients with this disease, he was able to find a bacteria, and actually a pretty cool bacteria now called Borrelia burgdorferi. It's a corkscrew shaped bacteria that is microscopic, so can't be seen, and it's transmitted by a black-legged tick, or the Ixodes tick. And once they found that there was a bacteria, then we decided, well, now we have something to target, and we quickly found out that we had antibiotics that could easily kill Borrelia, the Lyme disease bacteria. And so we gave the name because of the researcher Bergdorfer. We gave his name to the species Borrelia burgdorferi, but there are actually other Borrelia, other spirochetes. It's those spiral bacteria that cause Lyme disease and various other diseases. There's some other Borrelia that can cause it, but in the United States, the majority of the diseases that cause Lyme are caused by Borrelia burgdorferi. And you know, it's actually pretty interesting because Lyme is probably understudied and now is one of the most rapidly growing infections across the world behind like HIV infections. So it's not just common here in the United States, but it's also common in Central Europe, but can be seen in various other countries, and it's growing every year. So I think that's important to point out that this is a disease that's growing, and we don't have a lot of information, especially in the late manifestations of the disease. And we have treatments that work most of the time, but occasionally don't work every time. So there's a lot that is still yet to be known about the actual organism and how our immune system functions in relation to the organism. But now at least we know that this spiral bacteria causes this disease, and it's transmitted by a certain type of tick, and it typically occurs in certain regions where the tick is present. And unfortunately, Wisconsin is a hotbed of these ticks, of the black-legged tick. But also, as we talked about, Lyme, Connecticut, the New England, and the Mid-Atlantic region of the United States is also a very common place where we see Lyme disease and these ticks.
I think I heard that Wisconsin might be number one on the list. I have had my record number of acute Lyme patients, 6 this year. I used to average about 2 a year, but have had 6. I don't know if that's an indicator that it's becoming more common or just chance, but it's definitely a real problem. One of the satisfying things is every patient I've had with Lyme that I've treated with Lyme and acute Lyme has had that acute Lyme symptoms improve. What are the symptoms of relatively what we call acute Lyme?
Yeah. So Lyme is really interesting because there are different clinical features or presentations, as we say in medicine, depending on what stage of the disease. So we have a stage 1, a stage 2, a stage 3, but typically we talk about early Lyme and we talk about late Lyme. And when we are first infected with Lyme, or the bacteria that causes Lyme disease, typically people present with various aches and pain, some joint pain, joint swelling, some more generalized symptoms like headache or flu-like symptoms. Sometimes we get some swollen lymph nodes or glands. And the one that we always talk about, especially that's very testable because it's got a nice picture associated with it. But in early Lyme, we can get a rash called erythema migrans that typically we call, bullseye or a targetoid lesion, where there's we see a red circle and then we see a halo around it and another red lesion encircling. So it looks a lot like a bullseye. And that is very typical when you see it, that is diagnostic for Lyme disease. But a lot of times the rashes don't look nearly as beautiful as some of the pictures that you can see on the internet. So we can break up like early Lyme into 2 stages. There's the localized stage where you're just getting some of those things that we talked about, but there is a disseminated portion where the spirochetes are kind of everywhere. We can get some heart disease where we can actually have heart blocks or some inflammation of the heart muscle. We can get more malaise or fatigue, and then we can get other things like other rashes, other places on our body. and then we can have more arthritis and swelling. And then some of the other things we can see is a lot of nervous system changes, meningitis. Sometimes we can get things like Bell's palsy. So people will lose some of their tone in their face because of the inflammation associated with the Lyme disease. And then that's kind of those early symptoms. And then, like we talked about, this is kind of a disease that has various stages. There is a late or chronic stage where, if untreated, we can get prolonged arthritis and chronic arthritis. We can also have changes in the way we're thinking, behaviors, mood, and also fatigue. And so sometimes we'll see in the pediatrics world, occasionally we'll see kids with mental status changes, or they'll come in that with their behaviors that they're acting very inappropriately, and that can sometimes be a manifestation of late Lyme disease.
And in that early Lyme, with help differentiate this, all from my experience, the acute illness of symptoms is very significant. People feel pretty acutely wiped out. An example, I had a patient of mine who is an avid runner, probably would run 5-6 days a week for 6 miles, and got a fever, was run down and achy, and he loves to run passionately. And he's like, oh, I could barely get a mile and a half, and I just had to stop. I couldn't force. I was so exhausted. My head was hurting. It was completely wiped out. It's rare, and I don't think I've ever had any patient with that who said, well, I feel a little off. I have a little allergies. It's usually hitting you, it takes you out of commission, catches your attention with all of the symptoms, and are quite wiped out. The good news is, from all my experience in taking with acute Lyme, is that usually within a couple days, like this one patient who I saw on a Thursday, Friday, I said, by Monday, you're going to feel a lot better. And within a week, he was back running 5-6 miles and getting back, and it felt good. It's satisfying. Like, infections are satisfying when you can treat them. Obviously, that's one of the neat things about making that diagnosis, and it's great. I love when somebody has an acute Lyme. They have a rash. Sometimes the rash is often not that bullseye rash. And if the people are listening, if they have with cell phones now, just take a picture. I always say, take a picture of your rash. It's hard in medical school to you spend a month in dermatology clinic just to get good at describing rashes. It's a art form to that. But now with cell phones, taking a picture of things, and it's often a confluent, which means it's erythematous throughout or red throughout. It's not necessarily at center spot. That's also to be differentiated from a small little local, less than a centimeter local rash right where the tick might have been buried, but not causing anything systemic. And the rash typically occurs about 10 to 20 days, and the symptoms are about 10 to 20 days, an incubation from that. So in Wisconsin, it's important to ask the travel question, and it's not just, have you been in, like we had during COVID, a place where there was COVID, which now is everywhere. But, well, what were you doing 2 weeks ago? Well, in Wisconsin, we call it up north in the woods, but we live in Western suburban Milwaukee area where my clinic is at, and there's a state park just a few miles away. And I've had patients who just going through hikes through the grass and brushes. There's so many deer in my backyard alone. There are deer everywhere running through. So the proliferation of deer spreading the deer tick has just made it pretty easy. Any suggestions for people if they are out in the woods trying to help prevent getting Lyme?
Yeah, I mean, it's the whole life cycle of the ticks and all of its different hosts is actually really interesting. So really, you were talking about deer. So deer, that's where our ticks lay their eggs. Like that's where they build their families. And so what has to happen is, in order for them to lay their eggs, is they need blood meals throughout their life stages. And so what happens is, typically, once the eggs hatch, they end up turning into different stages, but one of the stages takes a blood meal on rodents, and they'll take a blood meal, and then they'll grow up, and then they'll go back to the deer, and then they'll live out their nice life cycle. Unfortunately, sometimes we get in the way of that cycle, and they end up taking a blood meal from us. So the cycle is pretty complex, but typically, when the nymph stage is developing, early spring is when kind of the most infectious period. That's when people get Lyme the most, because that's the stage that is the most that can transmit Lyme the best. But typically, where you find deer, where you find rodents, where you find grasses, that's where you're going to find a tick. So a lot of hiking trails, where there are trails, the grass at the edges of the trail, that's where the ticks want to be, because they know, they're part of their instinct is that that's where they're going to find the animals, and that's where they're going to find the mammals that they need to feed on. So it's a lot of times grasses, and ticks can't jump, so we have to be rubbing up against the grasses. They need to crawl on us. They don't really fly, so it's really those times where you're walking on trails or walking through grasses, and they're climbing onto us and climbing onto our skin. So if you're trying to avoid tick bites, the best thing you can do is avoid those areas. But if you're adventurous and you want to be out in nature, then keeping covered, making sure that you are using light clothing so that you can find ticks after your trails, that's really important. Using DEET on our skin, following those directions. The deep wood, typically DEET 30 to 40 is what we would recommend in our older kids and our adults, but obviously follow the recommendations on any of your cans of insect repellent. But also, if you are an avid hiker, having clothing that has permethrin in it, it's embedded into the fabric. So that's an insect repellent as well. And then always after hikes and being outside, checking your dogs, checking your animals, checking your kids, checking yourself, doing a thorough tick check after those events is really important. Other than that, just making sure that if you find any ticks, that you remove them as soon as possible. And we can probably get into talking about removal too. I guess I wouldn't be a good steward of tick information if I didn't talk about how to take them off.
Well, one of the things too, just with that, is if you get it off within 36 hours, you're pretty well in the clear, if you can be confident. So one of the things that I will tell my patients is, make sure you check in the morning when you get dressed, a careful self-inspection, or a partner can do a self-inspection on areas if you can't see, to make sure you don't have any. And then when you get in the evening, do another careful inspection, and in the morning, another self. If you keep doing that, if you're in an area, you can be, that vigilance can hopefully pick up something. We often don't do a careful self-inspection when we're going through everyday life, because who's caring if there's a little lint or something? But if you are in a known area that there are ticks, to make sure you can check, because that's one of those where, if I have a patient, we often get calls where somebody says, well, I have a tick, it's a deer tick, what should I do? And I said, well, where have you been? Well, I just was out yesterday afternoon on a Sunday, and they're calling on Monday. They weren't anywhere near ticks. Pretty strong support to say, good, you caught it early. The question is, if you've been camping for a week and you haven't been paying attention and you don't know how long it's in there, that gets to be that question. And sometimes people, if they're in a high endemic area, will do a 1 dose of like doxycycline or moxicillin, and then have careful surveillance. And depending on that, and it's a shared decision with the patient on how they want to approach that. But going now from acute, so that acute stage where often you're very sick, about 80% of the time you can have a rash around where the bite was. Half the people who have Lyme, they don't recall a tick bite. They don't see a tick bite because a tick got your blood meal. I love how you say that blood meal. It's all the
Yeah.
people who hopefully aren't eating right now.
Who knew? They didn't know they were signing up for like a vampire podcast.
I know my son doing gross anatomy right now has stopped eating chicken and turkey sandwiches over lunch. So you start
Yeah.
wondering about all of those blood related things. But so now move to from the early stage now to later stage. What are the symptoms of that?
Yeah, so this is still someone who has the bacteria that's present in their body. This is something that has gone untreated. Maybe they had very mild symptoms of early Lyme, or maybe they're a very sick person. We have lots of patients that we see that have aches and pains. They have different diseases, and if they get Lyme disease, they may not notice that they're having different symptoms, or they're not tested for Lyme disease. And we can put it on the providers as well. Lyme disease is missed often because it is so general at the beginning. You can have pretty general symptoms. And so this are the stages where we get kind of later on, and we can still have prolonged arthritis, but then we get some more chronic changes of how our brain works and how our nerves work. So sometimes people can get pain in our nerves, and we can get different changes in our behavior, changes in our ability to feel well rested. So people experience a lot of fatigue in those changes. And so that is someone who still has been infected with Lyme disease, but it was left untreated. So they have this prolonged inflammatory state from having Borrelia in their body.
So if there's clinical suspicion,
Yeah.
and I had a couple of patients who were initially missed when they saw a couple of writers had seen me, and I think if most of the time, if you get a Lyme question, and of course you're going in infectious disease, you never get those wrong. But if you have it laid up, the Lyme question on your board exam is going to have, a patient who's living in Wisconsin who has been hiking or outdoors, and they might throw in a few other things, and they show a rash that started 2 weeks after. Most make that diagnosis because they're keyed into looking for it. I had a couple patients who, in the middle of COVID, and we had kind of a mini spike of COVID, people were on that COVID getting like 3-4 COVID tests. And they're like, it must be COVID. And I'm like, no, there's a rash. Did you ask if they've been outside in the last 2 weeks or so? And well, yeah, I was camping. Here's a rash. And we find out they have actually acute Lyme. So how do you diagnose it? I know, like I've talked about in the podcast, and you've learned so much starts with the history. 90% of a diagnosis starts with a good history, but then we do use blood work or lab or other testing to help.
Yeah, I think this is kind of where things have been recently changing, but typically what we use early on, we take a couple approaches. So usually what we do early on is we do some antibody testing. And we can do is we can look at the different types of antibodies our body makes against certain organisms. In this case, we would look for antibodies that are created against the Lyme bacteria, and we can use that to see what's if we had an acute infection, or if we've had an infection in the past. That was something that we had used in the past. but there is a lot of different laboratory testing that have been created, different DNA tests and different tests using, proteins from the bacteria, so some of the components of their cell wall, in order to come up with the testing. So there has been some recent changes to testing and diagnostics, but for the most part, if we think about testing, we right now the CDC recommends two-step testing. Both steps are required, and they, typically we do the first step, and if that's negative, then we don't do the next step, and we do that in the hospital pretty much all the time. So that's how we make the diagnosis.
But what are the two antibody tests? There's the first one, kind of a screening. What is that called?
Yeah, so we have a screening test. Typically, we have the IgM and IgG testing to detect antibodies, and then we have more spirochete specific testing that we would follow up with. So one screen is to try to catch as many people with Lyme disease, and then our next set of testing is actually to find those people that truly have a Lyme infection.
Yeah. So there'll be a IgM and an IgG, the acute, and then more chronic stage if they've had the infection for a longer period of time, that those show up. And how accurate is that two-stage in picking up Lyme?
Yeah, so we do actually a really great job at, if we're following most hospital systems and healthcare systems have adopted this two-step process. And if you come into the hospital or if you come into the office, the lab does this in the background. So we can put in we put in a Lyme test in our health system, and the lab in the background is running both the initial test, and if they need to do the second test, usually it's reflexively done. And so most of our lab protocols include that in order to diagnose Lyme. And we do, like we said, with this two-step process, we are able to diagnose Lyme very effectively. We are able to capture, upwards of 90 some percent. I think the issue becomes when, if people are infected too early or too late and the wrong tests are done, then sometimes that can introduce some confusion.
And I think I've had patients where we catch it so early, see it within a day or two, you see a rash, they're sick, they're run down, and we're treating if there's a high clinical suspicion. We're not waiting for that. And very often I've had where the IgM and IgG don't even come back.
Yeah,
because they haven't had an immune response, and creating antibodies has not come back yet, and they get better. And we clinically say, well, there's a acute Lyme symptoms, there's a rash, and they've gotten better. So you can make it without that confirmatory IgM and IgG. A couple of my recent patients who've had this, they had been seen probably a little for a week or two, or had symptoms a little longer, where the IgM came back positive and IgG was negative. I had a patient who had thought she had chronic Lyme, or had been told she had chronic Lyme, which we'll talk more. But when we got, and all the testing that she had done previously by traditional doctors showed that she never had Lyme, but she had seen functional medicine physicians who told her that special testing, PCR and other testing, and that are more in the alternative medicine world, showed that, well, you actually did. Well, interestingly, when we did the test, she came back positive for IgM, which means she had an acute infection, but was negative for IgG, which showed that she never had a past infection, which other labs had shown in the past. But she did actually, maybe for the first time, likely had that acute infection, and she was really run down, and she was tired, had a headache, and we treated her, and within a few days she got back to her baseline symptom of having some chronic fatigue and some brain fog, but not at the severe level or acute level that she had previously. So, and there's regimens we use for treating, standard regimens, typically doxycycline. If people can't tolerate that to allergies, there's amoxicillin you can use for some neurologic or potentially late symptoms, IV ceftriaxone. And most of what I read, and correct me if I'm wrong, is that long courses of antibiotics are not indicated based on the evidence.
Yeah, I mean, I think it depends on who you ask, but right now, the data suggests that in acute Lyme, doing trialing the 2-week course is typically what we do, and we usually generally try to use a longer course for the late stage of Lyme disease. But even then, long is relative because we're talking typically on the order of a month. And so in the past, we were doing a lot longer treatments for chronic Lyme, but we've shown that these shorter courses are just as effective as the longer ones in the past.
So what we've talked about, most people would say isn't very controversial.
No.
Some out there may say that they feel that the testing may not be accurate. Like I talked about, we both feel it is, and the infectious disease doctors you work with and the standard of care shows that those are effective, and doing other testing is not indicated. Now we move into what's called chronic Lyme, or also known as post-treatment Lyme disease syndrome. And, I sent some articles to you talking about this, and kind of leading this next discussion that I think a lot of people will be very interested in is, I want to say that there's a lot of despair of patients, or with patients who have chronic Lyme or post-treatment Lyme disease syndrome. They're more likely to be impaired with working, their social or family interactions. These patients have diminished well-being and health-related quality of life comparable to people with other chronic illnesses, even though post-treatment Lyme disease syndrome or chronic Lyme is a severe and possibly chronic illness that is likely to become more familiar with the growing number of Lyme disease cases. Relatively little is known about it. Researchers have not been able to identify why it occurs, what its predisposing factors are, and most importantly, how to diagnose, treat, and prevent it. As a result, patients as well as physicians have minimal guidance, which creates room for error. And due to lack of effective treatment options, these patients may turn to less evidence-based medicine and may then, what some feel, prey on their fears of desperation and answers for help. A study published in 2015 found over 30 alternative Lyme disease therapies via a Google search, including ultraviolet light, urine ingestion, bee venom, and stem cell transplantation, none of which are supported by evidence-based medicine. Physicians are equally challenged by the lack of post-treatment Lyme disease syndrome information, as studies have shown that about 48% of primary care physicians were undecided about the existence of chronic Lyme, and 49% did not believe it. Chronic Lyme existed, and only 2% previously diagnosed and treated chronic Lyme disease. That leaves a lot of patients out there, again, in that despair, wanting to get answers. And when traditional medicine doesn't provide answers, then the world of alternative medicine is out there to offer explanations and solutions, often that there is a hidden Lyme infection that's persisting throughout the body. And for those of you who are listeners of the podcast, I talked about this a little bit with Margaret Mitchell, who wrote Gone with the Wind. She lived 100 years ago. And 100 years ago, infectious disease was getting in its prime. The germ theory was out there, and this whole idea that you could have this microscopic organism spreading throughout the body, wreaking havoc, was accepted. And then within a couple decades, the discovery of penicillin and eventual other antibiotics was such a game changer in the world of medicine. And so it's fun or exciting and satisfying as a physician to diagnose people who have infections and treat them. So with that kind of background, I want to, again, reinforce that these patients who are going through this have real symptoms and they're having real pain. And unfortunately, I think often are really feeling dismissed and brushed off by physicians, as you've said in the start of the podcast, just haven't had a lot of experience and comfort. And often they are shoved to different silos of medicine. And in this world, they'd often be sent to the traditional infectious disease silo. And I often have said that for many just general doctors, the fibromyalgia patient is often the least wanted patient to see on their schedule because the average doctor doesn't want to help care for them. And I would imagine on the infectious disease world that somebody who comes in and probably from the traditional medicine side and the infectious side would say, oh, well, they claim they have this chronic Lyme infection. I've heard that even some infectious disease clinics won't even see somebody with chronic Lyme because they don't want to waste their time. So with that said, can you shed some more light into this whole area?
Yeah, no, I think that all makes a lot of sense. I think, being a patient that has this debilitating disease, you always want an answer. You want something to blame, and if you had a recent Lyme infection, it's easy to say like, oh, I have Lyme or chronic Lyme, and and definitely there's probably some association. I'm sure we'll talk about more about infections and how they relate to fibromyalgia, but we're talking about a disease where there's lots of different manifestations of symptoms because of the disease. So we said that there was acute and chronic signs and symptoms of the disease. And that's when the bacteria is present in our body. But now we're talking about a disease that's real, pain that's real, and symptoms that are real. But now we don't have that bacteria is not present anymore. That the Lyme is not there in the body, but people are still having symptoms. And so there's people want to say, this is untreated or I need more antibiotics, but that's clearly not exactly what we need to do. And that's what this podcast is set up to talk about, is in these scenarios where people are having real symptoms and real pain, and they've been dismissed by various specialties. This one being dismissed as not having Lyme disease, but that doesn't answer the question, what do I have and how do I fix it? And so I think that's why we're here today to discuss this, is to bring awareness to these post-infectious syndromes, and in this one in particular is this post-treatment Lyme disease.
And in the study or paper that I will have available in the show notes, it talks about where they have had patients and done randomized or placebo-controlled trials and look to see if there are any differences in outcomes in the chronic Lyme or post-treatment Lyme disease with antibiotics, and showed that there was no real significance in difference in symptoms, which then, I just did a 3-part podcast series talking about paradigms and meta-narratives and that overarching story. And we want to latch on to an overarching story to explain our symptoms. And part of this is medicine's own fault, because we've done a great job in the last 100 years to explain medical problems. Probably most of what you see in your medical residency, you can really share what's going on. You're on just finished hematology oncology, and there's such a robustness in how much research. And since I was in medical residency and to what's going on now, the treatment choices for chemotherapy are incredible. There's diseases that we can improve so much more of the outcomes. And we have identified genes and multiple genes that are involved in these cancers. Correct me if I'm wrong, right?
Yeah.
Just having finished up. And you can do a really good job to explain things. Now, unfortunately, we don't always cure people who are going through hematology and oncology problems, but at least we can have an answer and understand it. And there's not a huge controversy surrounding that. We're doing our best, and there scientists are trying to discover better cures for treating cancer. And when you're on the cardiology wards like you are going through now, cardiovascular disease, you can see plaque buildup and all the blood pressure and all of the things. And so there's there's a great understanding. I'm a clinical
robust research, especially in cardiology. I mean, everyone around the world is studying cardiology, and for certain medications, we even know specific people from specific countries that won't respond to medications because there's so much data. So I think it's cool that we have all that evidence for cardiology, but in these diseases that people feel uncomfortable about, or that don't have clear definitions, or don't have the money to back up all the research, I think that's where we don't have all that evidence, we don't have all that support. And it's nice to be on those services like hemonc and cardiology, because we have the answers. I've got the treatments, I've got tests and tools, and I don't have to live in the gray area. I don't have to live in the area where it's like, well, I don't we know what's going on with you, and I know what we need to do to get you feeling better, but other doctors are going to tell you that what you're experiencing isn't real, or it's not. So I don't have to practice that when I'm in the hospital generally.
And that leaves the chronic Lyme, fibromyalgia, post-Lyme treatment type patient almost like an orphan in no man's land, where nobody wants to take this foster disease home. Everybody's sort of kicked it out of their house and shoot it all around, and it's left in the street for somebody to try to make sense out of things. And some have said that leaves them prey towards medications that don't have the strong evidence to support their outcomes, lead to high expense. I had a couple patients just in the last year who found me who were spending tens of thousands of dollars on treatments for chronic Lyme, when their regular doctor had never made that diagnosis, didn't have the testing that showed that, but went to what some were referred to, or was self-referred to, as a Lyme literate doctor, who then did some special testing to show that they actually did, but there were all these different supplements. One was getting IV ozone therapy, one was getting chronic, also part of the treatment was chronic antibiotics, lots of supplements that were being used. I had a patient who brought in a grocery bag full, and when the interesting with her is she had been told she had fibromyalgia in the past, but her doctor said, well, you can try some duloxetine, that's a generic for Cymbalta. Didn't give really minimal education on what fibromyalgia was, discussion, and tried a dose. Maybe if she got 10, 20% better, but didn't even know that she might only get 10, 20%, 30% better on that, and not expecting the cure like we get typically with acute Lyme. And then was just muddled up with these chronic persistent fibromyalgia symptoms, then got self-referred or found a Lyme literate doctor, who then said, oh, we got the answer, we know what's wrong. And then being told, okay, you have this meta-narrative, you've had this chronic Lyme, and then was getting treated. Then she was struggling, and she was having to take so many pills in the morning, literally like a cereal bowl full of supplements, that to get them all down, she would feel sick with all of the supplements she was downing in the morning, let alone the cost. She was spending out of pocket tens of thousands of dollars, racking up bills insurance wasn't covering. When I saw her, we were able to diagnose and treat her fibromyalgia and tie things together under that understanding, and is now doing so much better. But if there's not other doctors out there making those connections and giving those explanations, they're going to be left frustrated. And maybe with long haul COVID, which I think carries a lot of overlap with other potential triggers for fibromyalgia related problems, that unmasking of maybe a predisposition will help. There's lots of money being put into COVID research, obviously, with the major impact it's had in the world and financial impact and life impacts, that more understanding will go into that. But again, often when you're doing research, these end up getting in silos, right? Where somebody's trying to find, oh, was there an infectious disease? I talked on a blog about how with long haul COVID, they found that all the acute inflammatory markers within a month were gone. And yet there were persistent symptoms. And I think that carries over so much for acute Lyme. You can have that acute cytokine release and the symptoms, and now the inflammation, the infection is cured or gone, yet people have persistent symptoms. Speaking of cytokines, what are these cytokines, and what symptoms do they have? What triggers them? And because I think that does play likely a role in the symptom that people who are having chronic Lyme.
Yeah. I mean, Lyme disease itself, like I said, is caused by a spirochete bacteria. And actually, spirochetes inside of us, they really, their job is to survive. I was always told in microbiology not to anthropomorphize microorganisms, so I shouldn't give them emotions and feelings and drives and goals. But as a life form, it wants to reproduce, and it wants to get to the next host, and it wants to duplicate. So its job is not to really kill us, but it doesn't mean that our body likes that it's around. So we have developed an immune system that is really great at detecting bacteria, really great at detecting viruses and all of the other organisms that are in our environment. And when we detect this bacteria, just like we detect all the other microorganisms, there's certain cells and certain immune modulators that are released in order to try to kill this bacteria. And some of those are cytokines. Those are just molecules that our body creates in order to ramp up our immune system, in order to try to kill off organisms. They have lots of jobs. Some call in other cells, some help develop and mature cells, and some switch our immune system into a high drive in order to kill certain organisms. So we have hundreds of thousands of cytokines in our immune system. And so Lyme is very pro-inflammatory. Like, that's why many of the early stages are inflammation. We have inflamed joints, we have inflamed nerves, we have inflamed hearts, we have all of these organs that are experiencing inflammation, because the spirochetes, the spirochete is not necessarily doing the damage. Our own immune system is causing inflammation at these organs, and it's wreaking havoc. So we always talk about how it's really great that we have an immune system, but there's many conditions where our immune system sometimes is a little bit over exuberant and can cause some issues. And so when we talk about these and when I'm in clinic with you and we're talking about these post-infectious syndromes like long haul COVID, or some people who have certain diseases like mono and all of these other diseases where they have long-term fatigue, pain after having infection. It's potentially triggered by like an inflammatory state or a cytokine, like you were saying. Obviously there's not great data or great research to suggest that, but that's just because the research isn't there. But I think that it's not unreasonable to think that that could be what's going on.
I think what the cytokines do is they make you feel, many of them make you feel run down, tired, sore, and achy.
Yeah.
It's that release. Often if many people have had influenza at least once in their life, and often before they get all of the respiratory type symptoms, they often the day before will just feel wiped,
I got hit by a
exhausted,
bus.
like they got hit by a bus and their body aches and is sore. And then they start getting the congestion and the cough and the fever preceding. And many people who have fibromyalgia will feel that they always are having this mono like influenza like, but it's not just 4, 5, 6, 7 days. It is weeks turning into months, turning into years. I talk about this in my book, Conquering Your Fibromyalgia, Real Answers and Real Solutions for Real Pain, that there's a mechanism for central sensitization that occurs with repetitive painful stimuli. It's called the temporal summation of the second pain, or TSSP, and it occurs in those with fibromyalgia more than those without. And this has been demonstrated where they did a study where people had repeated painful heat shocks to the thumb area of the palm. And what they showed is that compared to people who don't have fibromyalgia or that sensitive nervous system, those who do have fibromyalgia will have persistence of pain even well after the thermal stimuli is taken away. And I think that likely is playing a role, at least my opinion, with the cytokine storm or release, is that you have that initial achiness. The body is kind of, the pain and fatigue is turned on, the switch is turned on, and then the off switch is not turned off quickly. I kind of think of it as the analogy is you have a big balloon that's filled up with air representing pain. So you get an acute injury or acute inflammation where there's a lot of pain. Those catch our attention. I've had this loving to go for runs or play sports where you might roll your ankle and suddenly you have this shock go throughout your body. You might even trip and fall because it hurts so much. Then you pick yourself up off the ground and you realize, okay, it's just my ankle. I don't hurt everywhere. Often if you're watching sports, there may be an injury on the field and the person's down, the player's down, and they're not faking it to get a timeout that's through cheating, but they really are hurt, they're injured. And then you see them walk off the field. That's kind of an example where you have that acute initial pain. It hurts in a sense diffusely, but then relatively quickly you may go from diffuse to localized pain. And I think that probably plays a role with understanding the chronic Lyme symptoms, where there's that acute pain, and then there's somebody who's genetically more predisposed, who then gets into that cycle. And one of the cycles that often you hear with fibromyalgia is an acute injury. It might be whiplash, it might be a car accident. Often there may be acute stress, and in this case, acute infection with Lyme, or post-COVID where somebody gets acutely sick, but they never fully recover. And then there's a lot of other things that they were doing in life that were helping them, like regular exercise, good sleep, eating healthy. And when you start getting into this downward spiral, often people don't get back up because they're it's almost like they're set in motion. They're caught in quicksand, and or the struggle, and they're left trying to get help. And I think a good number of these patients are or meet criteria often then long-term for fibromyalgia with diffuse pain, brain fog, and fatigue. We're finding that with other disorders. I did just a series a month ago talking about chronic migraines and headaches and the connection with post-concussion. Often there's like, oh, wow, post-concussions and ADHD and migraines seem to have a connection. So it's trying to connect all of these dots. And as somebody who is an internal medicine doctor and a pediatrician who decided not to camp out on one silo, but be able to stay connected to all the silos and have an interest, it is very helpful for a problem like this to see how they're connected. And as you are in an academic center, a lot of the research dollars are in silos. There isn't a Lyme, or I should say, there's no Lyme clinic, chronic Lyme clinic at your academic center. Correct? That you know of? There's
That I know of. I haven't heard.
Yeah, there is, and there are around the country though. Post-COVID syndrome, long haul COVID syndrome clinics that are popping up. And I think research coming through there will help us grow in our understanding of these other post-infectious disorders. And I think a lot of the results are consistent with an acute stress causing persistent of symptoms, that on button getting kept in that more on position. And our hope, at least with the book and the podcast, is to give information. That's kind of what inspired me to write this. Is there's a lot of gray area, but there is a lot that we understand. But this is a lot more complicated than you have acute Lyme. Here's the rash. You can look at every website and see this and take doxycycline and you get better almost all the time. And research shows, one question that comes to my mind is how many patients who have that acute Lyme may have post-Lyme symptoms. And it's about, I think, 10, 12, 15% may have symptoms. And that's similar in that post-COVID long haul COVID, is that there's a certain percentage of who will have persistent long-term symptoms. Any other thoughts that you have?
No, I think, you know, working with the patients that you see, I think I've learned a lot. And, you know, on our journey to hike up the mountain so we can see from above. And we, you know, I think as primary care doctors, that's what our job is. You know, on our journey up there, we'll just avoid the ticks. But, you know, I think now that I have worked with you and I have a chance to think about these things, we have all this information. We have information about each disease that we talk about, and we keep joking about the silos, but we have all this information, but there hasn't been many people that have made the connections, or that we did, you know, that we are drawing connections between all of these diseases and how they're related. I think that's what we're missing in our education at the moment. And so I think you're right. As we learn more about post-COVID, and, you know, since it has affected so many people, there's more money dedicated to its research, and we might be able to learn more about chronic pain and fibromyalgia, and especially in relation to other infectious diseases and after they've been treated.
Well, thanks for joining me on the podcast here. I enjoy having you in clinic and enjoy teaching, and you're always eager to learn. And I learn from you. You know, you are, when you're in training, you get to keep on a lot of the inpatients and other things, and understanding more about these problems and staying close to the infectious disease world. And I know that when you're working in the future in infectious disease clinic in your training, that when you see a patient of these, you're going to have a broader understanding and perspective. Whether you then say, well, I'm going to take on comprehensive care, probably maybe not willing, but you're like, well, there is a doctor out
Yeah.
out there
Well,
that,
yeah,
yeah,
actually,
if you can see,
I
if
know
you
a
don't
guy.
mind, but he's pretty busy. But the hope of the podcast is to grow and shedding more light and understanding, so as many medical doctors out there can start to also connect these dots and have confidence. Unfortunately, in medicine is something that moves often slowly, especially if there isn't a great, quick, easy solution. When
Yeah.
the latest cancer drug that can increase survival in 50% of patients, and it's a game breaker, and or medications in other parts of the world, whether it's biological agents for treating rheumatoid arthritis and other problems, there is that, hey, we can cure and we can help, and things like insulin that allow people to live with type 1 diabetes. Using thyroid medicine to treat people who have thyroid problems is so satisfying. But often in medicine, in the primary care world, and I've had this in the last couple of days, where I'll say, I hope your thyroid in one sense is abnormal because you have all these symptoms, but I'm telling you, it probably is going to be normal. So let's go on that assumption, so that when it comes back normal, we're not surprised. We're kind of expecting, even though you might Google and find to say all of these symptoms fit. And you may have a lot of symptoms that fit exactly with Lyme. I feel tired, I have fatigue, I have these mental fog and brain fog, but, well, you don't have Lyme. And then there's confusion because some doctors may say, oh, well, you do, but they didn't do the right test. And then the patient's left in the lurch, left in no man's land, and who do I trust? And often for doctors, if you're not spending time discussing these, they will go to a doctor who will actually take more time. And I think taking time, maybe sending someone to listen to the podcast to grow in their understanding, reading more of the book, will help that as well. Well, I wish you the best. I know you're going to probably see me in a month once you wrap up
Yeah.
inpatient cardiology, and then you got fellowship interviews and all of that fun stuff going through the process. For those who are not familiar with at least how the American medical system works, but probably in a lot of the systems around the world, you try real hard, take applications to get into medical school, get accepted med school, then you start deciding what kind of doctor you want to be. And often that's a general, like it might be internal medicine, general surgery, and then you may specialize in cardiothoracic surgery, orthopedic surgery, or go on to be a GI doctor or infectious disease doctor. And then when you decide you might want to be an infectious disease doctor, then what's the next step?
That once I decide to be infectious disease doctor, then I have to do what I'm doing now and apply to different fellowship programs across the nation, and I'll interview with them, and eventually I'll make a list of where I want to go, and they'll make a list of who they want, and there's a computer system that tosses us together to make sure that everyone across the nation that's applying to that your specialty is best fit to the program that you want and that the program wants you. So it's a bit up to the computer system.
Yeah. So it's all very interesting, and going through that process, and then you finally get to complete that. And hopefully for yourself, as you're learning in the clinic, as you keep up to date on all the different infectious diseases, is to continue learning as a doctor,
Yeah.
advice for this. And I think it makes it exciting, is that there is always new things to learn. And there's a lot to learn with chronic Lyme. We don't have all the answers, but there's a lot of clues out there that suggest that there are things that we understand and that we can help people who are going through struggles. So, well, until I see you.
And hopefully I have this as a tool. I'll always be able to point them to at least the first step of their journey.
Yeah, it's often like, well, you don't have this, you don't have this. Well, actually, I think you have this. And that's often, in the world of what I do as an internal medicine and pediatrician, is I can say, well, you have this, and there's a doctor who treats this. You have a gallbladder that's full of gallstones that may need to be removed. Here's a surgeon to do that. You have an appendicitis. I don't treat that. And hopefully other doctors, if they're in a silo like infectious disease, can recognize and say, hey, here is an answer. Now, the real problem that may end up being is we don't have a lot of doctors out there who feel real comfortable treating this. So if you're around the world listening to this in the United States and in other countries, there aren't a lot of doctors ready to just jump on tackling this, at least in the traditional medical system. There's many doctors in the alternative medicine world who are putting their treatments out there and hope, but it'll be frustrating trying to find somebody who wants to work with helping those patients. And I really like helping people who are going through this. I found a lot of hope and satisfaction. All right, well, I'll let you get back to getting a little rest and recovery before you hit the hospital tomorrow. And again, thanks a lot.
Well, thanks for having me.
Put this on here. Stop recording.